Hi everyone, this is Dr. Rakshith. Greetings from Study MRCS. So here in this particular station, we are trying to understand about a skill station that is history taking. So how does a history taking station fare? So here the history taking station has three parts. Basically 1 minute for the STEM, 6 minutes for the discussion, and 3 minutes for the Viva. So here in this 1 minute, it is standing outside the station where you'll read the STEM. So you'll understand what exactly the station is. You enter the station, you talk to the patient, and these 3 minutes you talk to the examiner where he'll be asking you Viva questions related to the condition, differential diagnosis, how do you treat, etc. So this is about the history taking station. So there one important thing is there are two examiners in this particular station. This one is a normal surgical examiner where he'll be assessing your professional skills on how your professional skills is. When it comes to a lay examiner who is not a surgeon or who is not related to medical field, what he'll be assessing is professionalism, the way you're conducting yourself, the way you're talking to the patients, your sympathy, your empathy, all these things will be assessed by lay examiner. So lay examiner carries 4 marks, and the surgical examiner carries 16 marks. So 16 plus 4, that is 20 marks for the station. So we have to make sure you're not just taking a history in this particular patient, but you're eventually trying to make an effort to understand the pain the patient is in and try to respond in a proper way rather than just mechanically listening to the patient and summarizing your findings. So this is a very important thing that we have to keep in mind before we enter a skill station. So that is where most of the people with multiple degrees might fail because of loss of professionalism, lack of professionalism, or empathy or sympathy. So that is what we'll try to keep in mind, and we'll try to answer this particular station. So the stem goes on like this. A 32-year-old footballer presents to with a right knee pain over many years, recently worsened since past 4 months. He had a previous knee surgery for ligamentous injury. So what is happening here? So here they're talking about a 32-year-old patient who has presented to you with a right knee pain. So here there are multiple things that we have to know. So this patient has come to you with knee pain. So once you enter the station, we'll try to understand what are the things that we have to rule out. See, okay. So when you're talking about a trauma, so there can be high chances of ligamentous injury, meniscus injury. Patient has also undergone a ligamentous injury in the past. So here it can be a recurrent trauma. It can be a failed surgery. There may be a second time the ligament might have been injured or a meniscus tear may be high chances. There's a meniscus tear also. So here, keeping this in mind, we'll enter the station. So how do you go through this station? So that is first thing. First thing, when you enter the station, the first thing that you have to do is wash your hands and introduce yourself. Most important thing is who are you? And what is your position in this particular hospital? And first, once you have introduced yourself, you have to greet the patient. How are you doing today? And one important thing before you start your history per se, you have to confirm the identity of the patient. So you have to confirm the identity and are you talking to the same patient or not? And then you have to always tell the patient what exactly you're going to do. For example, you should tell the patient, I am going to ask a brief history about your condition today. It will involve me asking few questions regarding your condition. I'll also be taking some notes as well. Is it okay with you? So once you explain the procedure to the patient, what exactly you're going to do, and you obtain the consent of the patient, then only you're going to proceed further. Till then, you're not supposed to proceed further. So we have confirmed our identity. We have told him who we are. We understood who he is, and we have taken a consent. And next, we'll proceed with a proper history taking. Now, how do you open your station? So you can start to talk to the patient. How can I help you today? Can you please tell me why are you here today? So that's something like that. Then you can start with the actual questions. So in any stations of history taking, once there is a pain, so once we know there is a pain, we have to follow the Socrates protocol. So we have to understand what exactly the pain is, how much is the pain is. So here one more point before you start actual history is you can ask the patient whether if he's in too much of pain. You can offer the patient analgesics before you proceed. Once you confirm the patient is comfortable, then only you can proceed with the station with further questions. So here talk about Socrates protocol. Socrates is a very important protocol. Please try to mug this up. So every time you enter the station with a pain, with a patient with a pain, you have to make sure all these questions of Socrates have to be asked. Okay. So what most important, we'll start with the S. That is the site. Where exactly is the pain in the knee? It can be in the medial side in osteoarthritis. It can be a patient can tell it's overall in osteoarthritis in an older age group. Patient can have a knee pain on the medial side. If the whole of the knee is hurting, it can be other conditions as well. If the lateral aspect is hurting, there can be lateral meniscus tear. Okay, so where you have to, if the posterior aspect is patient can have a Baker's cyst as well, or there can be muscle tear. If the pain is just below the knee on the medial side, it can be pes ansanis bursitis. Okay, a lot of bursa around. So this is something that we have to know. So we have to understand where exactly the pain is, and how did the pain onset, whether it is a sudden in onset, like immediately following a trauma. So that can give us a traumatic injury, like a meniscus injury. If it's an insidious onset, that can again be osteoarthritis, where it's an insidious onset and gradually progressive. What is the character of the pain? It's a dull aching pain or it's a sharp type of a pain. So that is very important. If the patient is able to locus, for example, in meniscus tear, when the patient is trying to squat or is trying to sit cross-legged, that time the patient will have severe sharp pain. In an osteoarthritis, patient might not have a sharp pain, he might have a dull pain. Then you have to ask about the radiation. When the patient, the pain is just stays there or it goes below or goes above. So we have to understand because it can be neurological pain as well. Then what is the time? How long the pain has been? That is a very important. If it's a chronic type of a pain or it's acute type of pain, then exacerbating and relieving factors. Whether the pain is always there, or some patients tell you the pain is on the rest. Some patients tell you pain is while walking, and some tell you like when I go to rest, there is no pain at all. Then the pain again when I get up in the morning, the pain is there. So we have to understand when exactly the pain is. Why is this important? Is because for example, when you start talking about inflammatory arthritis, this pain is usually in the morning stiffness, morning pain is there. As the sun comes up, the pain goes down. But in mechanical arthritis, the pain comes usually after a day's work. Okay, so that is also important. Then what is the severity of the pain? The severity is a very, very, very important thing. So before we start questioning the patient further, we have to understand how much the pain is. For example, in osteoarthritis, the pain might not be so severe. It might be somewhere around 4 or 5. How do you ask this is something like is from when I take a scale from 1 to 10, 10, 1 being the least pain and 10 being the severe pain that is there. So where do you want to grade it? So if is the pain affecting your daily activities, is the pain not letting you sleep? So all this put this in the pain towards severe type rather than a simple type. So these are the few questions related to pain. So once we have understood what type of a pain is this, then we can go for further with other questions. So now we have understood the pain. So what are the other questions that are? We have to rule out everything. So one thing that we have to rule out is deformity. For example, in case of osteoarthritis, so if the patient, what happens in osteoarthritis, if there is a bowing of legs can be there. So is there any deformity of the bone? When do you see a locking? So when we consider a meniscus tear, a medial meniscus or lateral meniscus tear, the patient might have a locking feature. And patient tells you, I walking most of the time, my knee gets locked and I have to shake it out and straighten it out. Some locking can be there. So giving away is a classical feature of a ligamentous injury like ACL or a PCL injury, or it can be MCL or LCL injury where it's an unstable joint. There can be numbness. So any knee injury can be associated with a neurological deficit. Patient can have some amount of numbness just below the knee or above the knee or the thigh or the lateral aspect of the thigh. Can ask the patient if there is stiffness, for example, in case of rheumatoid arthritis or ankylosing spondylitis, monoarticular rheumatoid or osteoarthritis patient might have some moment of stiffness, especially in the mornings. Then, if you're talking about infections, if there is a local infection, if it's acute case infection, patient can have swelling, redness, and warmth as well. You can ask the patient, have you noticed any swelling or redness these days? So that is one thing that we have to ask. Any rashes can also be asked. Maybe it can be associated with other skin conditions like psoriatic arthritis that usually affects a smaller joint. So, but like this, we have to rule out mechanical arthritis, ligamentous injuries, and other conditions of rheumatoid arthritis, psoriatic arthritis. It can be associated with bowel conditions as well. So we have to rule out other conditions as well. So in these questions that we ask in differential diagnosis, we will get a positive answer, maybe osteoarthritis or maybe giving away sensation or locking. So that thing we have to make sure we have noted that down. Following this, we have to ask about past medical history. Is the patient taking any medications for any other underlying conditions or any other knee surgeries, anything that the patient has undergone? The past medical history, surgical history, and drug history. So these play a very important role in a diagnosis. Then we have to ask for social history. What does the patient do? Who he lives with? And before asking his histories like his habits, like alcohol or smoking, then we have to make sure that we take the proper permission with the patient and whether he's comfortable sharing that. So these things have to be asked in a proper way where it doesn't actually hurt the patient. You can ask them, can I ask you a few questions, few personal questions regarding to your habits, something like that, and you can then proceed. After you asked everything, the most important thing is ice. Ice, we have to make sure that we have made sure that we have to compulsorily ask and we have to cover this. So ideas, concerns, and expectation. We have to understand what exactly patient thinks about his condition. Some might think that my some of my grandmother had cancer, so I might have cancer. Some might have Googled already and they think, yeah, I have a ligamentous injury or meniscus injury. So we have to understand what is actually running through his patient's mind and what does he think about that? For concern, some people might be very scared. They might die because of cancer. They might think that my knee pain might be there for years. So that is what the concern is. And what are expectations? Usually, the patient want this pain to go away, and they want to lead a normal life. So these are some of the expectations from the patient. So we can understand how we can help the patient exactly. So ICE plays a very important role when it comes to a differential diagnosis and understanding and helping the patient as well. So once that is done, then we have to give a proper history. Then once you are done, you make sure you have to help the patient, thank the patient. Thank you for cooperation today. I've noted everything down. I'll discuss with my senior consultant. I'll get back to you. Do not forget what we do is most of the times we just finish the history, we finish the examination. Then we just turn to the examiner and we just tell them start summarizing. But we never thank the patient. We never help the patient dress up in case of other examination. So we have to make sure that we have assured him that dignity that he deserves, and then we start summarizing to the examiner. So basic history on what exact who the patient is, what about the patient, what are the positive signs that you have elicited, and what it can be. So everything you can just put in a summary and you can just summarize that to the patient. Then later summarize that to the examiner. After that, that will be followed by a brief viva on differential diagnosis and management. After that, that your session concludes. Okay, so this is about the history taking. Thank you everyone for watching the video. Thank you very much.